I'm Edwina Brown, and we are going to be talking about conservative care. This is the choice of a non-dialysis pathway by older and usually frail older people with advanced kidney disease. The talk is going to include the concept of frailty, dialysis outcomes if old and frail, what is conservative care, outcomes on conservative care, and choosing conservative care. So what is frailty? Frailty is a state of decreased physiologic reserves or dysregulation of multiple physiologic systems that is associated with age and or chronic illness. It usually presents as a composite of poor physical function, a feeling of exhaustion, low physical activity, and weight loss. It is associated with a higher risk of falls, cognitive impairment, hospitalization, and death, and is much more common in the chronic kidney disease population than the general population. There was an excellent review about frailty in The Lancet in 2013, written by Clegg et al. And what frailty is the difference between the lady on the left, who is clearly fit and able to go swimming, and the lady on the right, who is equally frail and equally aged 80 and is frail. In other words, she is dependent on others for her usually daily activities and is close to the end of life. Frailty is also associated with increased vulnerability. And this graph really shows what I mean. So the line at the top in green is the lady on the left, aged 80, going swimming, who gets a minor urinary tract infection, has a drop in her overall functioning, but rapidly gets back to normal. The lady on the right, who may just have a bit of independence if she gets a urinary infection, is really going to be severely affected. Her function is going to go down. It's going to take a long time for her to recover, and she will not get back to where she was before. Frailty also affects the trajectory of decline towards the end of life. The line in blue is what happens in people with cancer. They have good functioning really into the last 2-3 months of life. People with single organ failure have periods of decompensation and a general decline, and you never know which of these blips is going to be the last one. And people with frailty just bounce along at the bottom. So what are the implications of being frail? It's obvious that it is associated with worse physical function and quality of life. There's a high incidence of geriatric syndromes such as falls, delirium, cognitive impairment, and dementia, increased admissions to hospital and prolonged lengths of stay, and increased mortality. And this is true for all conditions, not just dialysis. Frailty is actually quite easy to assess, and the easiest way for nephrologists is to use the Canadian study of health and aging frailty scale. This has been well validated and is associated with increased hospitalizations and death. There is a score of 7 points, going from 1, which is very fit, to 5, which is mildly frail, which is with limited dependence on others for instrumental activities of daily living, to severely frail, which is completely dependent on others for the activities of daily living or terminally ill. These different categories can be quickly determined just by taking a history from the patient. And this has an impact on outcomes. So this is a study from Halifax in Canada, which shows that the higher the Canadian Frailty Scale, the worse the outcomes, with the red bar being people who died, the blue being transplantation, and green being still on dialysis. So what are the dialysis outcomes if old and frail? In 2009, the New England Journal had 2 papers on this topic. So this is one by Vanita Jassal from Toronto, showing that roughly about 100 people starting on dialysis, with the majority being independent at home. Within 6 months, there is quite a dramatic shift. So within 6 months of starting dialysis, and this was a mixture of both hemo and peritoneal dialysis, you can see that only 25% of people are still independent at home. Some now require some assistance at home, and others have moved into residential care. So there's a rapid decline in physical functioning in people over the age of 80 starting on dialysis. And this study comes from the United States and looks at people who are in nursing homes. And as you can see, within 3 months of starting on dialysis, about a third have died, a third have got decreased functional status, and a third have got maintained functional status. And within 12 months, almost 3/4 of people have died, and only a tiny percentage has still got maintained physical functioning. So what is conservative care? Conservative care is a non-dialysis pathway which is chosen by patients after shared decision-making with the pre-dialysis team. It is still active management, with management of anemia with erythropoietin and intravenous iron, blood pressure control to slow the rate of decline of kidney function and also lower stroke risk, optimize fluid balance, avoiding over and underhydration. And remember, this is really important for older people, many of whom lose their ability to recognize thirst. Symptom control, including pain control, is really important, and joint management with palliative care teams at the end of life phase. How this is actually done is going to depend on local resources. So in some centres, you can have combined kidney and palliative care clinics. In other centres, patients are managed at home, mostly using primary care and community palliative care, and maybe visits from a community renal supportive care team. In some places, conservative care patients are just seen in a specialist conservative care clinic, and in other places they remain mixed with general nephrology patients. So what are the outcomes of conservative care? There is quite considerable evidence now looking at survival from retrospective studies. This is not as easy as it seems, because you know when dialysis starts, that's pretty obvious. But when does conservative care start? Some people have conversations about conservative care. In other words, do they want dialysis or don't have dialysis when their GFR is 20? Other people have conversations about conservative care when their GFRs are 10. So when does conservative care start? The way people have got round this in studies is to look at people in a renal clinic and select a cohort of people all with the same GFR, and then follow them forward. So the first study first largest study that did this was from the Lister Hospital in Stevenage in England. They chose a GFR of 15, and they looked at people over the age of 75 who subsequently went on to renal replacement therapy or elected to have conservative management. The graph on the left shows the outcomes for people with low comorbidity. And yes, in this group of people, those who chose renal replacement therapy, which is the top line, had a better survival than those on conservative care. However, if patients had high comorbidity, then the median survival was identical. And what is really striking in this and in other studies, which I'll be showing you, is that all the patients on renal replacement therapy died within 3 to 4 years, whereas in the conservative care group, there was a tail, so that about 20% of them survived for very much longer. This is another study from Leeds in England, which looked at people under the age of 80 and those over the age of 80. And they have looked from a GFR of 20. Those who are under 80, people who started dialysis, which is the top line, had a better survival than those who chose conservative care. If you were over 80, there was absolutely no difference in survival between those choosing dialysis or those choosing conservative care. And similar data from looking at physical functioning. So a WHO performance status of 3 and above is where people require assistance for daily activities. So if people had scores of less than 3, in other words, they had good or reasonable physical functioning, yes, dialysis, which is the top line here, provided better survival than conservative care. But if people had poor physical functioning, then there was no difference in survival, whether they chose dialysis or had conservative care. And similar data in a more recent study from the Netherlands, looking at people aged 70 to 79, dialysis provided better survival than conservative care. If you were over 80, no difference in survival, and again, the long tail of people who chose conservative care. All of these studies have the limitation that they've been based on pre-dialysis clinics. In other words, people known to nephrologists. It does not, none of them address the outcomes for people who present more acutely as crash landers or requiring dialysis in a short period of time. This is another way of looking at the outcomes of conservative care. This data comes from the Royal Free Hospital, and they defined conservative care as starting at the median GFR that their dialysis population started dialysis. And what this graph has done is to look at survival in people on hemodialysis, which is the bottom bar, and those on conservative care in the top bar. So the grey bar is length of time in months at home, or in other words, hospital-free days. The dark grey bar is length of time in hospital, and the pale grey days having dialysis. And what you can see is that actually hospital-free days are very similar for the conservative care and the dialysis population. There's not much data about quality of life. This is another study from Stevenage looking at a concept called changes in satisfaction with life score. And they compared people who started hemodialysis, started peritoneal dialysis, people on conservative care, and those who hadn't made choices and died before requiring dialysis. This group were very sick and therefore, not surprisingly, had lower satisfaction with life scores. You can see that in the hemodialysis and the peritoneal dialysis groups all had a drop in satisfaction with life score, which never went back to the baseline after starting dialysis. And in the conservative care group, their satisfaction with life score was stable. And one last bit of data, again from Fliss-Murtagh, looking at the trajectory of mean palliative care outcome scale over the last year of life. And what this study consisted of was of about 70 patients who had chosen conservative care, and she phoned them every month to complete this palliative care outcome scale. And then she looked from the time of death and tracked the scores backwards. And you can see that this score, which really reflects both physical and emotional functioning, was very stable until the last couple of months. So how should one choose conservative care? Conservative care has to be chosen by the patient after shared decision-making with the pre-dialysis team. It should not be imposed on a patient. There are going to be patients where we feel that dialysis is completely contraindicated for medical grounds. That is not what conservative care is. Conservative care is for people who are stable enough to be able to make a decision about dialysis modality or choosing not to have dialysis. So what is shared decision making? So shared decision making is a complex process of communication where the information and thoughts of the care providers are shared with the patient and their family. It is not a one-off conversation. It is often over multiple visits, and it consists of patient being able to access information and sufficient information, truth-telling, understanding what the concerns and expectations of the patient and family are, actually presenting all the options and likely outcomes from those options, pros and cons, having trust between the patient and physician and care providers, providing appropriate evidence, good communication, and having a good relationship between the physician and patient. So conservative care, as I've said, is chosen by the patient after shared decision-making with the pre-dialysis team. Before having the conversations, as the care provider, it is important to consider evidence of frailty and how severe is this, comorbidities and their severity, and likely outcomes of hemodialysis and peritoneal dialysis for the patient. There is no point in thinking that somebody who has had a stroke is unable to walk, that person is going to be able to suddenly go back to being normal, having started on dialysis. And the conversation with the patient, including the family or carers, must include a realistic prognosis, likely outcomes on hemodialysis or peritoneal dialysis, what the patient wishes regarding the quality of life, what the patient wishes regarding their end of life. Do they want to die in hospital? Do they want to die at home? Do they want their end of life to be medicalized? And also giving the patient the knowledge that he or she can change their decision at any time. I'm going to finish with a painting by Edvard Munch, a Norwegian painter of the 20th century. This is his last painting. There was a whole article in The Lancet about this some years ago. It is a self-portrait. Behind him, the bright area, you can see him and his life, his paintings, his reflections on what he has achieved. The bed represents mortality and death, and the clock with no hands shows that he does not know when this is going to happen. Older people with advanced disease often know that they are going to die. All of us are going to die in the end. How we spend those last months or years with major illness is the choice of that individual. It is not surprising that many older people with advanced kidney disease choose not to have dialysis. By giving them the appropriate information, we can help them make that choice, and by managing that period of time well with good symptom control and enabling choices about end-of-life management, we can make that period of life as good as possible. Thank you.